With craniocervical instability, there are two main reasons why people develop increased intracranial pressure. Intracranial pressure means the pressure of the cerebrospinal fluid around the brain. One reason this happens is OA instability with an elongated styloid process. That elongated styloid process can compress the jugular vein, which drains blood from the brain. If the brain cannot drain properly, the blood backs up into the brain. This will cause increased intracranial pressure. That's one option. The other is actually cinching of the foramen magnum. So when the occiput, the base of the head, slides relative to the neck due to OA instability, you can get this cinching effect of the foramen magnum where the brainstem and the spinal cord exit, and that will actually restrict CSF outflow. So we call this CSF outflow obstruction. This we can measure with an MRI, but it has to be a seated MRI. Otherwise, when you're laying down, usually these are asymptomatic. It's when we're upright that the CCI actually succumbs to gravity and you get this shift of the head relative to the neck. With craniocervical instability, it's also not common to have an elongated styloid process. When this styloid process, which comes right down here, is elongated, it can cause compression of the jugular vein, and it can also put tension on the glossopharyngeal nerve, which wraps around it. The glossopharyngeal nerve, if there's tension on it, there's pain. We call it glossopharyngeal neuralgia. That causes either sharp inner ear pain or sharp throat pain. Usually it's worse if you look to the opposite side because that'll put more tension on it. So this happens with CCI because when the head slides at the OA, it changes the position of that styloid process, which then puts tension either on the jugular and causes compression, which can cause venous backflow into the brain, which causes increased intracranial pressure, or it will put tension on the glossopharyngeal nerve, which will cause glossopharyngeal neuralgia, or both. So to diagnose this, beyond imaging, which will actually show us the anatomy and show us the physical compression, we do a glossopharyngeal nerve block at the styloid process. And if that takes the pain away, that's confirmation that there is glossopharyngeal neuralgia. And so we take this a step back and then we discuss what to do about this longer term. So for the glossopharyngeal nerve block, here, we identify the stylohyoid muscle because it's usually easier to see and find than the styloid process itself. And basically, as long as we inject along that, we will capture, our intended target. We'll pinch here. You may twitch right along here, and right here is where we want to go. Do you feel that? Right there's the spot. So that should be adequate. I'm going to put a little bit extra right here just to be thorough. You okay?
Yeah.